Hi, thanks for asking me to talk today. So basically, I work in the Memory and Cognition Clinic at RPA and also in the Motor Neurone Disease Clinic at the Brain and Mind Centre, and see a lot of the patients that have the crossover between motor neurone disease and frontotemporal dementia. And so that's what I'm going to talk about today. So in overview, what I'm going to talk about is what do we mean by ALS or MND and FTD? What are the clinical forms of FTD? As Margie alluded to, I'll talk to you about the C9orf72 mutation. And then a couple of key symptoms that we see in ALS FTD, including apathy and changes in eating and metabolism, how we might assess cognition and behavioural change in the clinic, and then some difficult issues about PEG insertion and non-invasive ventilation in ALS FTD. So what do we mean by ALS FTD? Well, essentially, what we're learning more and more is there's a spectrum of disease. So at one end, we've got ALS, which is MND, so patients present with muscle weakness, bulbar palsy. But what we're learning is more and more patients also develop cognitive change. So at the other end of the spectrum, we've got frontotemporal dementia, and then there's a mixture of patients in the middle that have ALS, FTD, and then what we call ALS plus, which are patients with cognitive and behavioural change that doesn't meet the criteria for the diagnosis of ALS, FTD. ALS and FTD are linked by a common pathology, which is the TDP43 protein. And also, as Margie alluded to, in 2011, there was the discovery of this gene called the C9orf72 mutation, which links families with both FTD and motor neurone disease. We know that approximately 10 to 50% of patients will have cognitive changes, and it depends where you work on the estimate of what patients have cognitive change. Probably 10 to 15% have ALS and FTD, but 50% will have subtle behavioural changes or changes in cognition. So in 2017, this new criteria for the diagnosis of ALS FTD came out, and this was essentially a collaboration between researchers from around the world, from the US, from the UK. And essentially, when we talk about ALS and FTD, there are several domains that we look for cognitive change in. So the first one is what we call executive and social cognition, language, and also memory, and then behavioural and neuropsychiatric symptoms. They've come up with 4 kind of labels for what we can label patients with. I think it doesn't really matter what we label patients with. We can just say they've got cognitive behavioural changes. But they've come up with ALS with cognitive impairment, ALS with behavioural impairment, ALS with behavioural and cognitive impairment, and ALS FTD. So it becomes quite complex and probably isn't that usable in a clinical setting. So when they talk about what we mean ALS FTD, they mean an evidence of progressive deterioration of behaviour and cognition, changes in behaviour and cognition using the criteria we use to diagnose FTD. They also talk about psychiatric and psychotic features, and they also talk about language impairment. So I thought the best way to kind of explain it to you was to look at what we mean by frontotemporal dementia, as that will make sense of what cognitive changes you may see in ALS. So when we talk about frontotemporal dementia, we talk about 3 basic areas of change. So the first area is behavioural variant FTD, or behavioural change, and that's where patients present with quite prominent behavioural and personality changes and have impaired emotion processing. So these are patients that lack empathy, they may be inappropriate, they may approach strangers, they may be extremely apathetic, so they'll just sit in the chair all day, not do their usual activities. And this is quite distressing for carers. The second type of area that patients may develop cognitive change is in their language, and we call this semantic dementia. And patients with ALS can develop this kind of change. So essentially they lose their knowledge of words and the meaning of objects. So these are patients that, for example, the wife will say, "Can you get me the tomato out of the fridge?" And the patient will reply, "What do you mean by a tomato?" or they'll say, what is a credit card? So they've lost that meaning of words and knowledge. The last type where we might see in ALS is progressive non-fluent aphasia, and that's where patients present with non-fluent speech and loss of grammar. And essentially, it's their speech almost sounds a bit like a stutter, and their grammar's not correct. Often the first thing they'll notice is in their writing, when they're writing emails, they'll make mistakes with their grammar, and we can see that in ALS. So in terms of the behavioural changes that we might see in ALS, they're very similar to what we see in FTD. So may make inappropriate remarks, impulsive, uncooperative, not interested in things, and difficulty with their normal activities. More recently, we've also learned that in ALS FTD there's a crossover with psychiatric symptoms, and this has really come about with the discovery of the C9orf72 mutation. And what we found is patients with this mutation and ALS or FTD can have quite prominent psychiatric presentations. So the interesting thing about this mutation is that it can present at any age. So we've got families where, for example, one son has MND, he's in his 30s, he has the mutation, but then his mother's presented in her 70s with frontotemporal dementia and also has the mutation. So essentially both of them are affected at the same time, but they're a generation apart. So it can spread across a number of ages. So what I'm going to do now is kind of move on to a couple of the other symptoms that we may see in both ALS and FTD. And Maggie mentioned Jazz, who's part of our group, who's looking at apathy in ALS. And a lot of patients and their carers will report before they present with anything, no muscle weakness, no cognitive change, the symptom of apathy and having lack of motivation. And a lot of people will mistake it for depression, and they'll get diagnosed with depression. And even in the condition, a lot of people think that it's depression related to the diagnosis, when actually it's a kind of part of the symptomology of the condition. It's apathy. It's probably got a neuroendocrine, neuroanatomical basis. And so it's part of the condition. So just dealing with the diagnosis won't necessarily solve the condition of the apathy. And it tends to get worse as the disease progresses. The next kind of symptom that I wanted to talk about that we see a lot in ALS and FTD is changing in eating and metabolism. And this is probably the question that I get asked most of all, kind of what can we eat to kind of help with the diagnosis of ALS? And it's actually quite complex because we know that in FTD there are quite prominent changes in eating behaviour. So patients can binge eat, they eat a lot of sweet food, they become quite rigid in what they eat. And it was originally thought that ALS was just a disease of decreased oral intake. Patients weren't interested in food and they lose weight, but it's actually quite more complex than that. So what we know is that patients with ALS are hypermetabolic, so they have an increased metabolic rate, but they also have increased cholesterol level and insulin resistance, which goes against everything that we're taught. If you're losing weight, you wouldn't expect to have a high cholesterol and a high insulin level. And the suggestion is that actually these changes are because of the neurodegenerative process, and that actually having a higher cholesterol level and being insulin resistant may be beneficial and slow the progression of ALS. We also know a lot of patients develop changes in their body habitus. So this patient developed for the first time in his life deposition of fat around his gut, where all his arm and leg muscles are wasted. So there are changes in metabolism in ALS. And the question is, are there also changes in their eating behaviour and what they take in, and can this affect their survival? So we did a study looking at eating behaviour across the spectrum in ALS and FTD. So we took over 100 patients and got their carers and themselves to complete surveys on what they ate over the preceding 6 months. And what we can see is that essentially a normal score on this survey is 0, so any change is significant. And what we can see is as patients develop the cognitive impairment in ALS, and even in pure ALS, they develop changes in their eating habits, so changes in swallowing, appetite, food preference, and eating habits. Also, what we found when we looked at their total caloric intake, again, ALS isn't just simply a disease of decreased caloric intake, it's actually more complex, and patients develop changes in their total caloric intake as they develop cognitive change. So as they develop symptoms of FTD, their intake tends to increase, even if they have swallowing difficulties. Also, interestingly, patients with ALS have an increased fat intake, and there is some research suggesting that this may precede even the diagnosis of ALS, and this increased fat intake may be protective in providing a nutrient to the nerve coverings, essentially, as that's made up of lipids. So actually this fat intake may be protective. We also looked at how the patient's body mass index may change as they develop cognitive changes. And as we can see, as patients develop cognitive changes, their body mass index also increases, even if they've got ALS and FTD at the same time. And I suspect that's due to the increased fat intake and the increased caloric intake. When we looked at what effect this has on survival, body mass index didn't have an effect on survival, but when we looked at the eating behaviour, those patients with more abnormal eating behaviour had a better survival than those patients with no abnormal eating behaviour. So I think this abnormal eating behaviour, the body's kind of a smart thing, tries to save itself. So patients develop these abnormal eating behaviours to try and provide themselves with more nutrients in a kind of hypermetabolic state. So I guess the point in clinical practice is we wouldn't worry too much about stopping patients eating, junk food and high caloric things. We'd actually encourage a high fat intake, a high protein intake, because that's the body's way of dealing with a higher metabolic rate. So what I'm going to do to move on to now is, in the clinical setting, how do we detect these behavioural changes and that patients may have symptoms of cognitive change? So we've got patients with pure ALS. How do we detect if they've got cognitive changes? So in our clinic, we use a measure called the Cambridge Behavioural Inventory, which is a very simple measure that carers complete, and they do it before they come to the clinic, and essentially they rank all of these symptoms involving memory, orientation, mood, beliefs, eating behaviour changes, disinhibition, and this gives us a good measure of whether there are behavioural changes. There's no point asking the carer in front of the patient if there are behavioural changes, because they'll never tell you. They'll say everything's fine. I did try it once, and the patient got really upset, and so we don't do that anymore. In terms of assessing cognition, a lot of clinics use the standard mini mental examination to assess cognition. Essentially, it's worthless to assess cognition, particularly because it doesn't pick up frontal change. We use the Addenbrook's cognitive examination, which takes about 10 to 15 minutes to do. It's very easy, anybody can do it. Normal score is greater than 88, and it looks at attention, fluency, memory, visuospatial function, and also language. And it's a good screening measure to whether a patient has cognitive change. In terms of treating the cognitive change, I think the most important thing is having an awareness that it exists. A lot of patients and their carers, when you give them the diagnosis of ALS, say, well, at least my memory and my cognition will be okay. At least I'm not going to go get dementia. And I think there needs to be an awareness that patients do have changes in cognition and their behaviour, and it needs to be discussed with carers, because often they'll come to clinic and the patient's done, funny things. We had one patient who essentially bought a $900,000 house off the internet without his wife knowing, because she didn't think that his cognition would be affected in ALS. So I think there needs to be, education of carers to keep an eye on kind of financial things, who's doing the banking, also looking at are they developing cognitive and behavioural changes. In terms of how we treat them, as a first-line drug, we use a lot of the selective serotonin reuptake inhibitors, which can help settle the disinhibition or the aggressive behaviour. When that doesn't work, the next line of therapy we'd use is atypical antipsychotics. So probably the nicest one is quetiapine or Seroquel. And we start at a very, very low dose, so 12.5 milligrams at night time, and just see if that helps the disinhibition, the agitation, or the aggressiveness. In terms of PEG tube placement and non-invasive ventilation, this is a really kind of difficult area. There is evidence, of course, in ALS that these two modes of treatment are beneficial, but most patients who have significant FTD and ALS will not tolerate a PEG or non-invasive ventilation. Margie will tell you stories of patients who've stuffed objects down the PEG tube, or they've tried to pull the PEG tube out. Also, they won't tolerate the mask because they don't have the cognitive ability to understand why they're wearing the mask. And often if you discuss it with the families and give them the option that, you know, they can have a PEG, they can have non-invasive ventilation, but these will be the problems with it, most of the families say no. So it's just having that, kind of giving them the option and then explaining how the cognitive and behavioural changes will affect that modality of treatment. And most families opt not to go with those options. In terms of what resources are available for patients when they do have changes in their cognition, probably the most important ones, everyone knows about ACAT, but just specifically for behavioural changes, there's this DBMAS, which is a Dementia Management Advisory Service. And essentially they have a behaviour response team, and that's for patients who have very significant behavioural changes. And essentially you can ring this hotline and they'll provide advice to the carers or the clinicians on measures that may be available to help manage the behavioural changes. The other good resource that's available for patients that do have FTD and ALS is through Alzheimer's Australia. So there's the National Dementia Helpline. There's also counselling. They run a very good living with memory loss program, and they divide the patients up into less than 65 years and those over 65 years. And that can provide a lot of information about managing, you know, the finances, what things to expect with behavioural and cognitive change. They also have a younger onset key worker program, and we've got a lot of patients who are managed both through MND Australia but also through Alzheimer's Australia for the cognitive changes and the support required around that. The only problem with that program is you have to be less than 65 years to be eligible. There's a couple of other programs that are available for people with dementia. There's the Art and Dementia program at the Art Gallery of New South Wales, where patients can go and with their carer, and essentially the carer does an art appreciation course, which sounds quite good. And the patient gets taught to kind of paint and also appreciate art. So it's something to keep people kind of active and involved. And they take allowances for people with weakness that can't paint, then they do more of the kind of art appreciation. The other thing to keep in mind is advanced care planning, and the kind of big question is driving and FTD, and this is probably the thing that causes the most kind of contentious issue. I've met some clinicians who say to patients with FTD, you'll be fine, just keep driving, which is a terrible response. So I essentially say to my patients, I don't think you should be, when you have a diagnosis, you need to inform the RTA. And I say to them, if you want to keep driving, then the only way we can do that is to have your driving assessed by an occupational therapist. And there's a number of centres, Calvary, I think St Joseph, or private occupational therapists offer that service. And essentially the occupational therapist goes out with the patient. And when you read the reports, it's quite interesting reading what some of the patients do. They almost hit pedestrians or go through red lights. And so I think it is kind of a worthwhile thing. having their driving assessed, and then you can say to the patient, look, it's not just me saying you can't drive, we've had it assessed, you can't drive. And then most people accept that. There's a couple of other things that are available through the NRMA for resources, and the other thing I discovered is the taxi subsidy scheme, which is very good. It gives people half-price taxis. So you can often say that when you say they can't drive, and most people are happy. So this is kind of where our clinic, we've got a multidisciplinary cognition clinic at RPA, and that fits in with the ALS clinic at the Brain and Mind in terms of managing the patients with FTD and ALS. Thank you.